Hi, and welcome back to Lecture 2, Module 4, Community Health Advocacy and Social Movements. This is part 2 of the lecture. In our previous lecture, we were talking about private and public funding for mental health care in the United States. Now we're moving on to managed behavioral health care organizations, which are basically managed care organizations contracted with external vendors that focused on mental health care. These external vendors became known as managed behavioral health care organizations, and we actually had a video about it in your previous lecture. So mental illness, children and adolescents. According to NIMH, the National Institute of Mental Health, 1 in 10 children experience sadness and depression. It is particularly difficult to assess teen mental disorders because of their stage in life and the hormonal changes that they're going through and growth and new experiences. So that's also, sometimes it's hard to tease out whether that's normal emotion or excessive. It is important that there is open communication with both children and teens, either with their parents, counselors, or friends, to ensure that if there is a mental disorder or even just a temporary condition, that it could be addressed. And as I said before, that's where the role of school counselors and college counselors and these support people really come in, because sometimes young people don't want to talk to their family about issues they're going through, and so that's an important resource. Mental illness in seniors and the elderly. So as we age, we will experience loss of family members and friends, which is a major trigger of depression and possibly suicide. I've experienced this with elder family members, that when they've seen their own friends and neighbors and people they care about in their own generation pass away, it causes a lot of pain about their, reminds them of their own impermanence. So elderly are often focused on seeing their primary care provider for physical ailments. So this is another barrier sometimes, which is that both the patient and the provider may ignore symptoms of mental illness because they're focused on a physiological or physical somatic illness. The primary care provider may not be comfortable addressing mental health issues, and that might be another issue with seniors and elderly, is that the primary care provider isn't used to dealing with mental health issues and doesn't know where to refer, or if they should refer, or if they should wait and see. So that can be a problem. If the primary care provider refers the elderly patient to a psychologist, a recent APA survey indicated that fewer than 30% of psychologists have had graduate coursework in geropsychology, which deals with mental health issues in the elderly. And I'm not sure that this specialization is necessary, but sometimes people who are highly trained can find early stages of mental illness, which might mean Alzheimer's or dementia or different conditions that the elderly population has, which can then be treated and sort of, controlled. So the APA has provided guidelines, Guideline 20, for psychologists to use for older adults. So mental illness, oh sorry, I'm ahead of myself. In the African American or Black American community, as we know from our textbook, that the Body and Soul, that there's a history there of medical discrimination, and that's a big barrier to seeking help with the mainstream medical establishment. So there might be community level, individual, mental, emotional, spiritual issues that are unresolved under the umbrella of mental health, because there may not be that trust in the health system because of the history and history of discrimination. So although the good side is, or the improvement here is that the percentage is increasing of psychologists, psychiatrists, and social workers who are from this community, and this will hopefully increase access and um, build a bridge between the medical establishment with this community where there has been a long and painful history. So if you remember Fanon, there are providers out there, and not to say that if you're a provider that you cannot build that bridge. Hopefully you will be part of building that bridge of trust and ethical and culturally competent care, whatever field you're in and whatever you're doing and whoever you're treating. So mental illness in the Latinx community is identified as, so this is identified as a high-risk group for depression, anxiety, and substance abuse, according to your Nancy Niles textbook. Like the African American population, Latinx may seek treatment from the clergy rather than specialists because of, again, that prejudice or racism that they may have experienced in the just mainstream healthcare establishment. Treatment through spiritual avenues rather than clinical sometimes are a more comfortable place to be. And there's a small percentage of Latinx who are mental health professionals. That number is increasing. So the small number can result in less mental health advocacy as a community for themselves and for the group, as an ethnic group. But again, it's a very diverse. Latin America is huge. Central America consists of several countries, and people have different languages, different socioeconomic status when they come here. They've come for different reasons. Some are migrant and will leave. Some have come to stay and maybe go to graduate school or do other things, pursue their dreams. So, and some are actually refugees fleeing violence, like in Guatemala. So there is a small percentage, and it's growing. And again, what I said in the previous slide is that we don't have to wait for Latino and Latina people to become mental health providers or healthcare providers. We can also be that bridge and provide safe spaces for people. The comfort level can be lower between patient and provider due to racial prejudice, as I said before. Sometimes it could be language barriers or cultural disconnect, and that could be in a spiritual sense or whatnot. So mental illness with Asian Americans. There wasn't much in the Nancy Niles textbook about this. Some of the things that they wrote were relevant, that they are less likely to report mental health disorders to friends or medical professionals due to cultural stigma. That is true in certain societies. Again, there's so many different cultures. There's East Asia, there's Southeast Asia, there's South Asia, which is where I'm from, there's Central Asia, and within those different Asias, there's several countries in each. So I think we have to, again, rewind and say, okay, Asian Americans, what does that mean? But yes, there are cultural stigmas that are common in Eastern societies, and your book says Oriental. That's not a PC word anymore. So you can call it Eastern. and often seek help for mental health disorders from alternative medicine providers, and those might be providers from the same culture. Um, Chinese people may seek traditional medicine like acupuncture or herbal medicine. People from India might choose Ayurveda, which is coming up in this lecture. And even people from Latin America, many are Christian, but many believe in their traditional healers as well, which are called curanderas. So, so there's a lot of alternatives as well. First generation immigrants, many Asian Americans are first generation or second generation, um, and they may have barriers with language or different understandings of things. So mental illness in American Indian and Alaska Natives, we'll just glaze over this quickly because it's a more complicated issue. In your other class, CHP 300, the Intro to Community Health, we even have a reading that talks more about historical trauma and how that influences physical health of American Indians and Alaska Natives. We don't get into it very much about mental health, and I think that is a very important link that even our guest speaker was talking about, which is how substance abuse is being linked more closely now with mental illness and trauma and different uh, conditions that um, that are superficially behaviors and bad behaviors, quote unquote, but are actually deeper issues. Um, so I'll just tell you some few statistics are that American Indian and Alaska Native youth are at higher risk of alcohol addiction at a young age, um, in addition to addiction for marijuana and prescription drugs. It's twice the rate of the national average, according to Nancy Niles' textbook. The IHS, Indian Health Service, currently funds 11 centers nationwide that address mental health and substance abuse disorders by providing holistic health care, which is culturally informed. Um, because sometimes these treatments, like traditional psychiatry or psychology, don't apply to the cultural or spiritual, what they call cosmology or sort of worldview of people. So these IHS programs are culturally informed and relevant. And so the IHS also uses telebehavioral health, and we've read an article in one of the classes about using remote consultation and screening, which is really amazing and a big development in mental health as well, which is a method of service delivery that broadens the availability to quality of and access to care across all behavioral health program areas. So this is a big step forward using telehealth. So mental illness in women, Nancy Niles gives a few statistics. Depression affects women nearly twice as often as men. I'm going to say that this might be thrown off by a reporting bias. Our guest speaker, Carlos, talks about that most of his patients are women. I think it's more acceptable, and he talks about how more of his substance abuse patients are men. So I don't know about this. It might be an artifact of lower reporting for men, but that's what's in your textbook. Some data suggest that women experience depression earlier in life for a longer period of time, more severely. Again, this might be due to reporting. Infertility, miscarriage, and menopause may instigate depression or mental illness. Some data suggest that having more children is correlated to a higher likelihood of depression. So we'll continue in part 3 of this lecture with with women.